Hi, I'm Dr. Donald Jurovich, and today we have a presentation on sleep disorders as part of our Dakota Geriatrics program, which is a program funded by the federal agency HRSA, and its program called the Geriatric Workforce Enhancement Program. So today's presentation is on sleep disorders in older adults. We want to firstly do a case study here. So 80-year-old female with she has 6 months of difficulty staying asleep. She frequently naps during the day, and it turns out that her nighttime awakenings disrupts her husband's sleep as well as her overall quality of life. So the individual falls asleep easily early evening and then wakes up about 2 hours later. During this time, she may go to the bathroom, she may putter around for a few hours, and she goes back and forth like this until her usual wake time of 6 a.m. So she, a sleep diary or information from the patient and the spouse indicates that she has at least 3 awakenings during the night. She sleeps after breakfast for a couple of hours and takes a nap or so in the afternoon, and she's irritable more in the evening, and importantly, she has moderate Alzheimer's disease. So here's a question for you. Which of the following is the best treatment approach for this person's sleep disorder? Prescribe melatonin, trazodone, or refer to cognitive behavioral therapy, or provide bright light exposure during the day. So go ahead and take your best selection. And the correct answer for this is bright light exposure during the day. So basically 2 hours of bright light therapy, 10,000 lumens would be the appropriate choice for this individual who has difficulty maintaining sleep at night. And it turns out that bright light therapy works both for the cognitively intact and for the cognitively impaired older adult. So important information there. Just turning to the objectives for this presentation, we want to look at the physiology of sleep change in the older adult, and then move to common psychiatric, medical, neurologic issues related to sleep perturbations, talk about the different methods for sleep evaluation and what interventions we recommend. So in terms of the topics, we're going to cover the epidemiology of insomnia in older adults, and we want to look at the evaluation of sleep issues, focus in on some specific issues related to dementia and sleep, and also how these sleep issues are different in the both acute and long-term care setting. So we know that sleep hygiene with aging is disrupted because of multiple chronic conditions. So we've mentioned previously that older adults break up into one of 3 groups. Either they have 0 or 1 chronic condition, another third has 2 to 4 chronic conditions, and then another third has 5 or more chronic conditions. As those chronic conditions increase, there's increasing incidence of pain. A lot of this can be associated with nocturia, particularly if somebody's on diuretics or has some form of diastolic or systolic heart failure. Compounding sleep hygiene are mood and cognitive disturbances, as well as the epidemic of sedentariness amongst older adults. We also know that there are recurrent sleep disorders in the older adult population, including obstructive sleep apnea, incidence of restless leg syndrome, and circadian rhythm disorders that we need to consider. So it turns out that women have more sleep disorders than men. African Americans have more sleep disorders than white elderly, and overall, there's about a 30% incidence of insomnia with the older adult population. As a consequence of that, 5% of older adults use some form of sleeping medications. There is an increased risk of death in the nursing home setting, or also with nursing home placement, I should say, with individuals that have persistent insomnia. And the subjective elements of sleep problems is linked to a poor quality of life. And importantly, sleep disruption can be an indicator of early cognitive decline. So here I want to show how melatonin spikes during night are altered during the aging process. So it's pretty evident here that the peak levels decline in older adult populations, as evidenced here in these 82 to 86-year-olds. There's other circadian rhythm disruptions. So you can see that temperature changes here. The red represents older adults, that you have lower temperature fluctuations. You have different levels of peaking and nadir cortisol levels. We already talked about the loss of melatonin cyclic rhythm, as well as the absolute amount, and then some subtle changes in the 24-hour glucose levels. So we know that the sleep characteristics do change with age. A lot of times there's a decrease in total sleep time. Sleep efficiency is less. There might be increased daytime napping, and that there's lower REM sleep. So again, the quality of the sleep decreases with increasing age. So in the clinical workup, I think it's important just to ask some questions. So the first one is, how is your sleep? And then if you do have sleep issues, do they interfere with your daytime activities? And then you can also ask an informant, so a spouse or a family member, if the older adult, your patient, has any issues with snoring, or if they've recognized nighttime sleep apnea or leg movements. In order to do a initial evaluation of sleep problems, it's good to use standardized sleep questionnaires. Certainly you can do a sleep log, much like we got information from our case study where the husband indicated that there were at least 3 instances per night where the individual got up for about 30 minutes and then went back to bed. You can also use actigraphy. So for those that have Apple Watches or other devices, you can actually track your sleep based upon movement. And then you also want to consider memory and depression screens, again, because cognitive impairment and depression can be associated with sleep disruption. So this is a prototypical polysomnography. It's best used for situations where you have sleep apnea, narcolepsy. I've actually been involved in some medical review of legal cases where an individual who's elderly fell asleep at the wheel while driving and ran into a group of motorcycle individuals across the other side of the road, killing one of them. And it was later found out that this individual had narcolepsy that was undiagnosed by the primary care provider. Also, polysomnography is important for periodic limb movement. And importantly, I want to point this out, that you don't need polysomnography for restless leg syndrome. So for those that are interested in internal medicine or geriatric boards, this might be an important question that may come up. So the DMS-5 category of insomnia disorder is defined here as difficulty in initiating or maintaining sleep. So are they having problems getting to sleep? Or if they are okay with getting to sleep, do they have problems maintaining that sleep? So that is associated generally with waking up a little too early. And it can be different periods of the night when they wake up. It could be like a couple hours after going to sleep, or it could be 4 to 6 hours. And then it's also often associated with daytime impairments, which include fatigue, poor concentration, sometimes forgetfulness, daytime sleepiness, and then overall anxiety and concerns about sleep. In terms of insomnia, it's often linked to depression and anxiety. And untreated sleep disorders themselves will reduce your ability to perhaps pharmacologically manage depression. And it's important to point out that caregivers have sleep difficulties, and we'll talk about that a little bit later on in this presentation. But insomnia is also closely associated with an increased risk of suicide, so that's another important correlation. Insomnia can be associated with multiple chronic conditions that we can see here. Probably the biggest issues that I see in clinical practice are those related to gastro reflux disease, that burning sensation and reflux disrupts sleep. Pain is also a big component, as well as Parkinson's disease or Parkinson's syndrome. So medications that can basically exacerbate or cause sleep issues are, as you might imagine, diuretics, particularly if you take the diuretics if the instruction is to take them at bedtime as opposed to at 4 p.m., you're going to have the effect of the diuretic in the middle of the night and causing people to urinate frequently. Remember, stimulants can disrupt sleep, and caffeine is basically a 24-hour drug. So drinking caffeine in the afternoon, it carries over into the next day, noon of the next day. So you can imagine how all that might impact your sleep. Bronchodilators, so the adrenergic system stimulation can cause sleep disruptions, and then also the adrenergic system being stimulated by antidepressants that are of the SNRI class. So those serotonin uptake and norepinephrine reuptake inhibitors can cause a real activating syndrome there. You can also get nightmares from cholinesterase inhibitors. So those would be the Ariceps and the rivastigmines. Parkinson's medications, all of them can be associated with nightmares, as well as the lipophilic propranolol. Medications that are associated with insomnia, chronic use of sleepers, sedative hypnotics, really disrupt the sleep quality, and they might lead to some form of tolerance. And if you stop them suddenly, they will cause rebound insomnia. So that's an important consideration, is that, as you titrate up on some of these medications, you need to titrate down incrementally. Probably the biggest problem I'm seeing there is that fourth point is alcohol use. I don't know if I want to say abuse, because it turns out that anything more than one drink per day can be associated with sleep disruption. So the combination of sedatives and alcohol can also compound sleep apnea, and so that's important, particularly in the individuals that have BMIs of 30 or greater. So that's always a word of caution. So let's talk about central sleep apnea. It's a central nervous system or a cardiac dysfunction that impairs respiration. So the question is it a result of disease, or is it a central nervous system disorder? Oftentimes we just don't know. So treating the underlying disorder really becomes important, such as good control of congestive heart failure, either systolic, diastolic, or both. In terms of obstructive sleep apnea, we know this to be a airway obstruction. Often it's reported as daytime sleepiness. Sometimes you wake up in the morning with a headache. The individual might complain of memory problems. Their personality may change. And importantly, in the clinic setting, if you see somebody with poorly controlled hypertension, let's say you've gone to a third antihypertensive and their blood pressure still is not well controlled, this would be something to consider as an etiology, obstructive sleep apnea. So obstructive sleep apnea is often associated with high BMI. And then again, just emphasizing that if resistant hypertension might prompt your thinking about OSA. And alcohol intake is an important risk factor. And obstructive sleep apnea can lead to dementing illness. It is also associated with cardiovascular disease. I mentioned about the motor vehicle accidents and narcolepsy, although there are two different conditions, but nonetheless, the daytime somnolence that's induced by sleep apnea can lead to accidents. We already talked that it might be associated with cognitive impairment, and it increases all-cause mortality. Now that contrasts with periodic limb movement during sleep. This is a stereotypic repetitive movements. It occurs during non-REM sleep, and it can only be diagnosed definitively with polysomnography. Now that contrasts with restless leg syndrome, which is considered a unpleasant feeling in your legs. A lot of times people call them cramps or a burning sensation. And it's just, you got to get up, got to get out of bed and walk it off. So this occurs in a fair portion of the population, and it does not require polysomnography to make the diagnosis. Some of the medications that can aggravate restless leg syndrome is our bad boy called diphenhydramine. Okay, so this is highly anticholinergic. It's unfortunately used frequently in the hospital setting as a sleeper, and it's really causes high cholinergic burden, and it's to be avoided at all costs if possible. Tricyclic antidepressants are also, all the antidepressants may aggravate restless leg syndrome, as do the antipsychotics. So one of the key things to think about in restless leg syndrome is to evaluate the ferritin, and restless leg is associated with low iron stores in the brain. So you might actually have a normal ferritin level in the blood, but studies have shown that there might be low brain levels. And this just kind of reinforces that. So there was a study that looked at cerebral spinal fluid ferritin levels in restless leg syndrome. And I just want to bring your attention to the fact here to the right that, firstly on the left here, the serum levels here in the middle are equivalent for ferritin, this middle graph. And then you can see the middle graph here on the right side that the spinal fluid levels are half of that of the, and actually less than the normal individuals without restless leg syndrome. So again, it just demonstrates that just because you have a normal serum ferritin level, you may have abnormal iron stores, which actually is an aging phenomenon. There's a certain percentage of the population that redistributes its iron into the reticuloendothelial system and then pulls it out of other tissue. So that may be one of the explanations for what we see in restless leg syndrome. So the treatment recommendations are to provide intravenous iron therapy for restless leg syndrome. The quick fix is to give a 1,000 milligram infusion as opposed to that 200 milligrams over 3 to 4 doses spaced by 2 weeks apart. Other non-pharmacologic treatments of restless leg include yoga, and exercise. So that's the non-pharmacologic interventions. In terms of the pharmacologic interventions, if your iron therapy doesn't work, you can use medications like ropinirole and pramipexole. There's equivocal evidence as to whether gabapentin works, but that might be another treatment choice. The real problem with these the Requips and the Maripexes is that in older adults they cause retrograde amnesia. So they'll take those medications and they'll just forget periods of time. So that's the wrap on those medications and why they should preferentially be avoided in the older adult population. There's some emerging evidence that high-dose vitamin D levels may actually improve restless leg syndrome. So trying to target 50 nanomoles would be another option. The circadian rhythm sleep disorders are also common with aging. Typically, these are individuals that fall asleep and then awaken early, versus the other version, which is fall asleep and awaken late. So those are the two considerations. It might be common in pre-dementia syndrome, so that's why I was saying that some of these sleep disorders might be a harborer of dementing illnesses, and you might want to do a little deeper dive in terms of evaluating their cognitive status.